I want people to look at menopause relative to something we're much more comfortable with, which is puberty. We go through this massive hormonal shift, hot flashes, night sweats, brain fog, and then when we start extrapolating backward, they're saying, wait. There's a whole 8 to 10 years before that where these symptoms are kind of creeping up. And so that's what we call the perimenopause. We can drop our cardiovascular risk by 50%, 50, for women on estradiol within the first 10 years of menopause. Now, if you can tell me one other thing that does that, if you tell me one other thing that I'll give you my life, don't think you're losing your mind. Don't let anybody tell you anything different, and get the vocabulary to check in, and then find someone actually who does deal with menopause symptoms. And we're all over the place.
Well, hello and welcome to this edition of Your Health, Your Wealth. I'm your host, Dr. Eddie Patton, and great episode today. I have a great guest, and to be honest with you, the reason I chose the topic for today's show is from feedback from listeners, and I talked to a number of listeners who wanted more information about menopause, perimenopause. This is a topic that I want to dive into that I don't think gets nearly enough attention, and we have just the right person, just the right specialist here today to help educate us all on this topic and others. So I'm joined today by Dr. Terri Samuels, board certified urogynecologist and female pelvic medicine and reconstructive surgeon. And her practice is called it's the Urogenius, right, Center?
Yeah, Urogenius. Yeah.
And I love the twist on the spelling and everything. Like, very innovative, and she has a lot of information out there on YouTube and her own podcast, Pelvic ND, which I'm sure we'll hear about it. So, she's helped countless number of women understand and embrace the stage of life with confidence and knowledge. So please, join me in welcoming Dr. Samuels. Terri, how you doing today?
Good. Thanks for having me. It's so good to see you.
Absolutely.
My favorite topic in the world.
Yeah. Let's start with the basics. So you hear perimenopause, menopause. So just maybe just explain us and me exactly, like, what's the difference in these terms? Are there different stages? How do you make that transition from perimenopause to menopause and so forth?
Okay, so let's look at it from a big picture perspective. I want people to look at menopause and the discussion regarding menopause relative to something we're much more comfortable with, which is puberty, right? We go through this massive hormonal shift, and our bodies make these changes, making the body capable of doing things it couldn't do before, okay? And now we're going to do the same thing. We're going to do it through a massive hormonal shift, and the body's going to behave differently. Our physiology is going to be different. When it comes to menopause, the textbook definition that you and I learned in med school was, 12 months without a period. And it was always centered around menstruation. So that was the marker, that was the be all end all. And you're either, before it, in it, or out of it, and life went on. Then we kind of got into hormones and what their effects were. And I think probably one of the first groups that paid attention to it was cardiologists, because we knew when I was a baby doc as an intern in England, when we had patients in telemetry in the early days, they used to leave the hospital in estradiol because we knew it protected them from heart attacks. So we knew that there were preventative aspects of it. Now we have a workforce that's getting older. Now we focused on women who are now producing in their 50s, right? I went to my grandmother's retirement party at 50. Like, she was done. She was out of the workforce. She was resting, right? Now we just revving at 50, right?
Yeah.
We revving at. So now we're expected to produce. We're having children later. We're doing all these things, and we're needing this physiology to keep up. But we're going through this massive transition. So now that we've been paying attention to quality of life, we're now looking at the whole picture, right? And so, okay, well, what are the symptoms are we having in those 12 months, right? And so, okay, hot flashes, night sweats, those are the obvious ones, right? Brain fog. And then when we start extrapolating backward, they're saying, wait. there's a whole 8 to 10 years before that where these symptoms are kind of creeping up. And so that's what we call the perimenopause. When the fluctuation, they're not done. The car hasn't stopped running, but it's sputtering, right? It's the hormones are just not flowing like a river anymore. They're kind of like poop, poop. So you're getting these big spikes, and then you're getting the symptoms that go with it. And so now we've recognized as the women, as women, we're producing more, we're doing more, that these symptoms started way before, and how can we mitigate them earlier to improve quality life and also look at that preventative side. So perimenopause is the 8 to 10 years before classic 12 months without a period. And during one of the first symptoms of perimenopause textbook is going to be menstrual irregularities.
Okay, and being a neurologist, I got to take this neurological, but I understand that sleep disturbances can be a part of that as well. Or maybe you can tell me like what the range of symptoms I do hear from people, and I got three older sisters that tell me that a lot of these symptoms are often dismissed or misdiagnosed. So, what are some of those more common symptoms, sleep disturbances, or different things that are often misdiagnosed or dismissed?
Right. So we're gonna focus on neurology for you guys. If you guys for neurologists, anything or any specialty where you have chronic disease, you will find that all your patients that go through menopause are much more difficult to manage. So your chronic migraines, your anything that has an autoimmune flavor to it it's gonna have, there is decreased blood flow with decreased estrogenation. So that's a soft call when it comes to brain flow that we feel, again, the data is soft, that estrogen may decrease that risk of Alzheimer's dementia, right? So then we talk a lot about brain fog going into the de-estrogenation because we're not getting quite as much blood flow, which we've shown on MRIs.
Yeah.
Other symptoms that are new to the game are palpitations. ER docs are complaining we're having patients, these women coming in their 50s in palpitations, nothing wrong with them, and often menopausal symptoms. Insomnia, definitively. Insomnia in and of itself, we're not exactly sure because a lot of them are concurrent with things like night sweats. So those are the hot flashes at night. And so it's impossible to sleep through those things. And then you talk about increased levels of anxiety and depression. So they're ruminating at night. And so they'll talk about that 3 a.m. wake up, circadian rhythm is off. So that also contributes. And you can have all of it. You can have one aspect of it. So we haven't defined that sleep portion in terms of directly related. Like if I give you this hormone, you're going to sleep well. We haven't gotten there yet. Hopefully we will. Other things are this new frozen shoulder, joint pain. So the rheumatologists are knocking on the doors now. All the chronic joint issues have become more difficult, especially without the progesterone. And then you have, obviously, the most important thing is libido and that lack of well-being when it comes to sexuality, vaginal dryness, obviously. So those things are obviously very important, especially in my world, in terms of we know what's going to happen, right? The skin is de-estrogenized. Your vagina is definitely estrogen dependent. And so we're going to have symptoms along those lines. But those are the new and exciting ones. But I can tell you, I probably seen the gamut, and I continue to see new symptoms. And
Yeah.
it usually is, I have never told anybody about this, but my right ear twitches. Okay? I get it. I mean, who am I to say that your right ear isn't twitching? But when I go on my estrogen, it stops twitching.
Yeah.
Great.
Wow.
So again, it's a constellation, and there are those who postulate up to 70 symptoms.
Wow. So it seems like it's more of a spectrum than like a one definitive thing. And is there any way to predict any health history or anything in a woman that can say, okay, you're going to be on the spectrum 1 to 10, or you're going to be all the way to 20 to 7, or all 70 symptoms? So, is it anything in the history that can give you some inclination as to that?
There's some data on obese women versus not. Obese women will tend to produce estrogens and estrogens in abdominal fat. One of the reasons we do tend to put on abdominal weight, and it's 100% of patients, whether you 110 wet or you're 250, but that abdominal fat is there because the body is trying to hang on to that estrogen and produce it, right? So the predictability varies. The one thing that is, I ask every patient is, when did your mother go into menopause? And
Interesting.
And that will usually give you some idea. Have you struggled with fertility over a long period of time? There are those who postulate that those who've had a lot of rounds of IVF may deplete their egg reserves, and therefore they may go a little bit earlier,
Mm-hmm.
depending on difficult hysterectomies, that kind of thing. So there are a bunch of soft factors. The one that's hard with some idea of predictability is the age of your mother.
Mm-hmm.
Some people with women who are obese that will have less symptoms often, and then more symptoms as they get older. Um, Women who are small in frame, they have severe symptoms, but just later. So those are the soft things that we see. But generally speaking, your mom's age is the most predictable.
Okay. And I know that in films and shows and everything else, it's different aspects. People joke about symptoms as far as menopause, but there is a large psychological component to this. You mentioned earlier as far as anxiety, depression, ADHD. Talk a little bit about that, the psychology along with
Psychology.
that goes along with this.
Well, it's really a tough time, because we don't have, our generations before didn't talk about it. We don't
Mm-hmm.
have the vocabulary for it, and we're doing more than we ever did before, right? So, and I always describe it as, when you're going through puberty, for the girl who's never been spoken about, who never had anyone talk to her, and woke up one morning and was bleeding and really thought she was going to die. I've spoken to hundreds of patients like that, right? No one
Yeah.
ever told me this was going to happen. I thought I was going to die, right? I was writing my will. It's kind of the same thing that a lot of women feel when they're going into their 50s, and no one's ever talked to them about it. And you get some idea, but you don't know the extent of it. And now you're like full force pushing to the other level in your life and career, and your body's just not cooperating, right? Things
Yeah.
were predictable yesterday, and now your body's not cooperating. I need to meet these. I thought I could. Yesterday I could, and today I can't. And so the psychology of that feeling of failure is very much real. And it's very, very difficult to cope, especially when you have severe symptoms that are outwardly, like things like hot flashes. I always talk about, people, women will come to me and say, how bad are your symptoms, right? And so I'll say, well, let's talk about one symptom in particular. Like, I ask them how much it bothers them, because you could be at home, and if you're lucky enough to be a homemaker, and you're getting a hot flash every hour, but you can walk outside, drink a martini, fan yourself, and it's not a big deal, right? It comes and it goes. But someone who's the CEO of a company with an all male employee list has a boardroom meeting, and every time at lunchtime she starts dripping on the table, right? That's going to affect her psychologically way more. You see what I'm
Yeah.
saying? So
Absolutely.
it depends on where you are in your life, what information you have, and how much support you can get. And that's getting better. But we need to start firstly with vocabulary, number one. And just as we did with puberty, like, you're not dying, right?
Yeah.
As a matter of fact, it's a better time of life because things can be more predictable and there's stuff that can be done.
Yeah, and I really appreciate what you said earlier about making that comparison between puberty because we can sometimes become desensitized to hormones and hormonal changes, and if if someone says, oh, I'm moody because of your hormones, or it's that time of the month, but hormones do have an effect on the brain. They do have an effect on your mood and emotional state.
Absolutely. Absolutely. I have a few thousand women here who will tell you.
Yeah. So all the
Oh,
guys
yes.
out there, don't hey, look, be sensitive now. Come on.
Yeah. For the guys, I just always tell you the best thing is just say, how can I help? Okay?
Exactly.
For the
Exactly.
women, we're working on our vocabulary to say, I just need this and this, right?
Uh-huh. I
So
like
we're
that. I
we're we're
like that.
getting there.
That's why I'm glad to have you on and for people to learn, because we need to learn the vocabulary and especially not because when patients come in and they say, oh, I've had brain fog or I'm going through a lot of these symptoms. A lot of it can sound like, oh, is this a TIA or is this and that, but now that I have been a little more educated on this topic, I am asking about other symptoms to see if maybe
That's
these
awesome.
are perimenopausal or menopausal symptoms. But
Yeah, absolutely.
all
And
right,
I think
so no, go ahead.
even our community as docs,
Yeah.
really need to become a little bit more sensitive. And again, you don't have to go into the nitty gritty. Send them
Mm-hmm.
over, send them with someone who will
Yeah.
sit and go through this with them. But your management is going to be that physiology, just like you did in puberty. You don't manage a 13-year-old the same you manage an 18-year-old, right? It's the
Mm-hmm.
same thing. You don't manage someone who is 46 the same way you manage someone at 52 because their symptoms can be different. It's different. It's different physiology.
So now what do we do about these? What do we do about this? Uh,
Do.
this I don't want to say condition, but it's really I mean
Transition.
this transition. There we go. What do we do
Yeah.
about this tradition? So, the hot topic, of course, is hormone replacement therapy. And my
Hmm.
first question about that is it really safe? And what do we know in the data about hormone replacement therapy and its safety and its effectiveness for treating some of these symptoms?
Hmm. Well, let's start with a little bit of history. So what made us scared of hormone therapy? So when I literally was in clinic as a baby doc after my internship year in OBGYN, and when the big doc came in and just did like this and took everything off the counter, right? The
Oh wow.
WHI came out and it said Women's Health Initiative kind of poo-pooed hormones. It causes breast cancer, increased risk of cardiovascular disease. This thing is going to kill women. And at the time, all we had was an oral option, and that was that. There was nothing else to do. Okay, and so again, and then the press got a hold of it, right? Condemned all physicians. What are we doing to women? We never needed this in the first place. And then now, 20 years later, we're back at where now we have research to show that we have actually calculated how many women did we kill by not having them on hormone replacement. Okay,
Oh
so
wow.
the two big things that were the concerns were cardiovascular disease and breast cancer. And if you look closely at that data, the WHI that didn't get promoted, why? Because it was the media got a hold of it, and as docs, we were too fearful. And I was in the Northeast at the time, which is obviously litigious. So we got that data, and it actually shows that there's a 22% decreased incidence of breast cancer with women on estrogen therapy. In addition to that, if you're on estrogen therapy when you become diagnosed with breast cancer, your mortality has been decreased by 44%.
Wow.
So like the
Okay.
data, and that was correlated with a huge Scandinavian Finnish study that showed a decreased mortality of 54% in women who were on estrogen before getting diagnosed with breast cancer. So we're definitely of the mindset where we're kind of, hold on a second, estradiol is not bad, and hold on a second, there may be benefits. Okay. In terms of cardiovascular disease, can say no more than American Heart Association, October 2023, came out with their report saying that we can drop our cardiovascular risk by 50%, 50, for
Fifty
women on
percent.
estradiol, 50% by
Okay.
women on estradiol within the first 10 years of menopause. Now, if you
Oh
can tell
wow.
me one other thing that does that, if you tell me one other thing that I'll give you my license. Nothing else. But we don't talk
Yeah.
about that. The media hasn't talked about that, right?
Interesting.
So yeah, so we now know that hormones have, as a matter of fact, are saving, and we knew that before the WHI came out from cardio. We knew that women did not start getting heart attacks until they got into their menopause. Now they were
Hmm.
often silent and deadly, but it was like our superpower, really. And then when you hit menopause, that risk factor went up in every single studies from the 70s and 80s. So we're definitely on, and then the black box warning came off. And so now we know, which came off about 4 weeks ago.
Oh wow.
Woohoo!
All right.
Yes.
Hot
Black
off the
box warning
press.
off.
Yeah.
Woo! Yes. So it's exciting, right? So now the question is, does everyone need hormones? Okay. And the answer is
There we go.
no, right?
Okay.
You don't need hormones. It is dependent on what you are trying to achieve. Okay. Now
Okay.
let's look at something like osteoporosis. Now, right, you don't feel any different, but if every one of in your life has died of osteoporosis, right? And you have osteopenia, At 51, it behooves you to get a treatment. Now, we definitively know that we decrease that risk of osteoporosis by having them on estrogen, right? So that's the preventative aspect also that is important, that doesn't affect your symptoms, but actually is important in terms of its work and its prevention. So overall, the benefits outweigh the risks, and it's just right patient, right indication, okay? Right delivery system, right amount. One of the issues with cardiovascular disease that we found out was, where were we getting the clots from? Where were we getting the thrombosis from? It was from first pass effect. So we were doing oral estrogen through the liver, we release clotting factors. So in my practice, no one gets oral estrogen. It is
Ah,
all dermal, subcutaneous, injectable, right? Because we don't want estrogen orally at all. So we have found a safe delivery system. It's just which one works for
okay.
you, right? And then we look at, no, the kicker with taking estrogen off the market was, we were like, oh my gosh, now we have to keep everybody's ovaries, right? Because we used to whip out ovaries with a hysterectomy in a heartbeat because we used to throw them on oral estrogen. Now we can't do it. I was like, oh my God. So
Uh-huh.
everybody's sitting on there going, what are we doing? So they started paying attention to what? Testosterone. And recognizing that women were, first, fun fact, we produce 4 times the amount of testosterone in our lifetimes than we do estrogen as women. FYI, okay? When that happened, we started paying attention to the testosterone levels, and we were like, okay, great, at least we can keep the ovaries because at least they may benefit from that little bit of testosterone because we have nothing else for them, okay? So we at least recognized it. And then there's been more data that's coming out in terms of testosterone indicated, right? By an ICD, by your ICDs for hypoactive sexual desire disorder, but we now have data in decreasing risk of osteoporosis. We have data on soft data on improved cardiovascular disease. So testosterone is now playing a role, and of course, progesterone was the offender in the
Mm-hmm.
WHI, which people don't realize. It wasn't estrogen, it was progesterone, and it was
Progesterone,
synthetic
okay.
progesterone. Okay? So
Mm-hmm.
anyway, I can go on forever about this. So I'm so
No,
sorry.
no. This is cool. This is exactly what, because I was actually going to ask you about the delivery system, because I have heard that data about, getting away from the orals, and now we got the patches, you got the topical creams, and on a side note, even in some of my patients with migraines, menstrual migraines, that some of them
Hmm.
said that their OBGYN prescribed like a topical cream that they can apply around the menstrual cycle, which actually helps with migraines as well. So it seems
Absolutely.
okay. So there you go. So it's not just the hormones; it's how a woman
How
gets
it's
those
delivered.
hormones.
How it's delivered. Absolutely. And you got to figure out what works for people. There are
Okay.
pros and cons to all of them.
And one other thing I heard that I know nothing about, and you can educate, is there such thing as bio identical hormones versus standard, or what is that about?
So synthetic.
Okay.
So a bioidentical, the best way to describe it, I hate using the word bioidentical,
All
is
right.
what you call isomolecular. So
Okay.
the molecules look the most similar to our naturally produced testosterone, estrogen, and progesterone. Okay,
Hmm.
and so they absorb a little bit differently. Okay, and we think that they have less risk than synthetics.
Okay. Okay. There it is. So let's say that you have a patient that maybe HRT, hormone replacement therapy, isn't for them. Are there lifestyle modifications or other things that women can do to help with these symptoms?
Yes, I mean, again, there's a laundry list. I will tell you the women who do best through that menopausal transition, especially, those who can't take hormones,
Hmm.
are gonna be your patients that are exercising regularly, okay, and you're keeping a good BMI. Those patients are going to be the ones that transition the best, okay, and they have the least number of symptoms.
Okay.
There are things on the market like Veozah, which help in terms of decreasing hot flashes. If
Hmm.
that's your primary symptom, then that's a great option for like women who have breast cancer who go into that immediate premature menopause or surgical menopause. It's a great way to mitigate if those symptoms are really bad, especially initially. There are other things, natural herbal remedies. And listen, I don't think that there is a separation between the two. I think medicine is medicine.
Mm-hmm.
Some medicine is more experiential, some is more academic. Okay, the experiential. If you find something that works to control your symptoms, I am all for it. I think the only patients I will push back on in terms of really considering hormones are those who may need that preventative aspect. For instance, if you have a terrible family history of cardiovascular disease as a female, you really want to make sure that you're mitigating that risk. One of the very interesting things that came up, and very interesting for Black females in particular, is an amazing study that came out that shows that women who are preeclamptic, and who had IUGR, which is small babies, because of blood flow issues and
Mm-hmm.
gestational hypertension, are 3 times more likely to have cardiovascular disease, which includes heart attacks and strokes. And
Yeah.
so those women have to be mindful of, hey, that risk factor, whatever the risk, your lifestyle, family history, but that pregnancy risk is very real. So that woman, we need to have a good conversation on what this could mean for you. The other thing to bear in mind too is that we look at other hormones, the thyroid in particular. We're pretty
Okay.
comfortable with the fact that the ovaries aren't producing as much. We're good at
Mm-hmm.
that. But we also have to recognize that these things, the thyroid gland, it often doesn't produce as much as it used to. And so sometimes that may need a little bit of supplementation. You want it to take, right? I always tell patients, what age were we meant to be dead?
What age are we meant to be dead?
Yes, evolutionary, without surgery, without sanitation,
Yeah,
okay,
like
and without
45,
vaccination.
50, something like that.
Right. So 47.
Yeah,
47
47.
is our expiration time,
Yeah.
right? So the question is, how do we get beyond that, right? The ripe old age of 47, which I'm nowhere near, just FYI.
Look, hey, look, I make the same argument when people ask me, well, what, with Alzheimer's and dementia, Parkinson's, say, look, the number one risk factor is getting older, and we've done such a good job as physicians in treating heart disease, cancer, those type of things, that we're living longer. So we have to
Mhm.
deal now with these things that come along with age. But it still beats the alternative, though.
Yes, yes. There it does. There's an option, right? There's an
Yeah, there is
option.
an option.
Yeah. Yeah, no, and I think it's huge. Testosterone has been a huge part of it too, in terms of understanding the role, and
Hmm.
making sure that women know that they have permission to use it.
Absolutely. And as we kind of wrap up here, a couple of things in part, and I want to make sure at the end that we, put your information out there, because certainly, having you here in Houston as a resource helps, particularly when people have these questions, women have these questions. But so when should women seek help, as opposed to just kind of trying to tough it out, and particularly with dealing with this particularly if they have bad menopause, perimenopausal symptoms, is it best to see a specialist like yourself to make sure that they are up, that they get the latest data and the latest treatment options available?
Right. I mean, that's really a philosophical question, right? It's like,
Hmm.
do you want, for there's always going to be that person that wants the very best, right?
Hmm.
Menopause, what I don't want people to do is, I get a lot of people who will poo-poo OBGYNs who aren't doing menopausal medicine, and I get that. But it's like saying, but my answer is always, well, do you take your 13-year-old to your OBGYN? And the answer is no, because she really doesn't do puberty, right? You're asking a little bit too much, and we're not trained in it. So again, finding someone when you have serious symptoms that are affecting your quality of life. One of the first symptoms is going to be period irregularity, but mood swings and hormonal changes and shifts that you can see. A lot of the symptoms we just talked about, insomnia, brain fog, it's affecting your ability to function, vaginal dryness. These are things that, as they come up, you'll notice. What I want you to take a deep breath and go, hold on a second. I want you to think. this could be me going through menopause. Okay?
Yeah.
That's what I want you to think. Like, don't think you're losing your mind. Don't let anybody tell you anything different, and get the vocabulary to check in. And then find someone actually who does deal with menopause symptoms. And we're all over the place.
That is
So
great
don't be
information.
scared.
Yeah, don't be scared, and also be cognizant that of the impacts on long-term health, like
Hmm.
dementia, heart disease, bone health, things that you mentioned, because there can be a long-term health risk with this as well. Correct?
Absolutely, that quality of life. It is a, I argue with people all the time that, there are all these symptoms, and for each of those symptoms, I can give you something, right? I can give
Hmm.
you something for your ADHD, which can be a symptom, for your depression, for your anxiety, for your insomnia, right? I can rack up 10 meds for the symptoms I told you, right?
Hmm.
Or you can try a molecule that is not tricking your body, that your body looked at it and goes, I know exactly what that is, and I have a receptor for it.
Hey, it's just already there. You already got the receptor for it.
It's already there.
All right. So in closing, what would you want to say, or what would you wish for women who are younger, in their 30s and 40s? For those listeners, what's the most important thing that they need to know, just about this whole this issue, and about this period of time coming up? What would you want to to them?
Well, the thing is, I get from young people is that, oh, I hope I don't go through that menopause. But who are the people who don't go through menopause, right? They're dead.
Yeah.
So it is, it is a chance for us, if we live long enough to go through it, right?
Yeah.
It's awesome. But I want, as we've changed as a society and we've embraced puberty, I want them to embrace menopause. I want them to start feeling the symptoms and go, all right, I know what to do with that. And I want people to start thinking, because I've seen it happen in my practice, and that's how we talk in this practice. May not be for everyone, but we
Hmm.
are like 50 and over, best years of your life, and we're going to make it the best years of your life. How are we going to do this, right?
That's
So I
right.
want people to, I want people to celebrate. When my daughter, had her period, we went out. She knew what was going to happen. She knew we were going to have a party, right? And
Hmm.
so, and it was to celebrate her womanhood, and we were going to shop and do whatever she wanted to do. And I want women to feel that way about menopause.
Wow, hey, that's great information, and very, very empowering as well. So, Dr. Terri Ann Samuels, thank you so much. It's so good to see you again. So, tell
Pleasure.
everybody how to get in touch with you, and some of your social media sites as well.
So our handle is terry and samuels.md, and we are on Instagram and TikTok, and our podcast is the Menopod, and our second series of the Menopause, which is on Apple and Spotify, is Sex After 70, which is really, I have the best patients in the world, so it's so much fun. And then we have HoustonUrogynecology.com. You can actually
Okay.
make appointments by just texting and saying contact us, and you can text us and make an appointment. Listen, I'm happy to serve. Can't wait to meet y'all. This is an exciting time to age. Exciting.
Excited. Thank you so much. This has been wonderful. I know we're gonna have to do it part two, because once listeners listening, like, hey, I got these other questions you didn't ask.
Question.
So
That's what I
look,
love.
look.
Yeah.
I'm sorry. I know I couldn't get to everything, but that just is more of an indication to keep tuning in, and we're gonna have Dr. Samuels back for part two.
Wonderful. Thanks
Thank you.
so much. So great to see you.
Absolutely, and thank you for tuning in. And if you enjoyed this episode, and truly got some, this was great information that was dropped today. Share it with others, like it, subscribe, and we'll see you for future episodes of Your Health, Your Wealth.
Absolutely. Thank you.
Thank you.